Hello, everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar. Doctor, this patient is really sick. Early detection of the sepsis patient, as well as building Muse and sepsis safety nets. And now, I'd like to introduce you to Angela Craig, who is our moderator today. Angela is a clinical nurse specialist in critical care for ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. She is the Sepsis Coordinator Network Advisory Committee member for Sepsis Alliance, and she is an expert in the field of sepsis awareness and management. Angela has published and lectured extensively at numerous nursing conferences and webinars on the topic of sepsis. Angela, welcome, and I'm so glad to be working with you for this special session, and we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
Yes, I am. Good morning and good afternoon, depending on your location. Thank you, Emily, for that very kind introduction. The title of today's webinar is Doctor, This Patient is Really Sick, Early Detection of the Sepsis Patient. And speaking today on this very timely topic is a colleague and wonderful friend of mine at Grady Health System in Atlanta, Georgia, Barbara McLean. Barbara McLean has been in critical care practice for over 40 years. Currently, she is the Advancing Evidence-Based Practice Clinical Specialist for the Division of Critical Care at the Grady Health System in Atlanta, Georgia. Barbara is a member of many professional organizations, including the American Association of Critical Care Nurses, the Society of Critical Care Medicine, and the American Association of Surgery and Trauma. She has been awarded the Excellence in Education Award by the AACN, as well as the Circle of Excellence for Clinical Practice in 2000 and 2014, and the SCCM has presented her with the prestigious Norma J. Shoemaker Award for Critical Care Nursing Excellence in 2013 and the Joseph Ray Brown Award for her contributions to critical care practice in 2016. She is considered an expert on sepsis identification as well as therapeutic implementation strategies for identification. She is an expert consultant for the National Advisory Board for the Sepsis Alliance and is considered the most valuable player in the sepsis initiative at Grady Health Systems. We have continuing education for nurses and respiratory therapists with this webinar. This educational activity is approved for 1 contact hour. A link to obtain CE credits will be available at the conclusion of this webinar. And CE accreditation information is provided on this slide as well. Support for this educational activity is provided by Philips. Our speaker has disclosed the following: Edwards Life Sciences and La Jolla Pharmaceuticals. And Barbara, are you ready to get started, sister?
Yes, I am, and thank you so very much for that lovely introduction, Angela. I appreciate it very much. And I also want to call out to Philips for their support of this webinar and supporting us in our critical care practice every day. I am very happy to be speaking with you today, and my focus really is about building safety nets for patients utilizing Muse and sepsis reminders, both on paper, in our minds, and electronically. So to begin, again, thank you so much, and I just want to let everyone know that there should be an email contact for me, and I'm happy for you to email me any questions or any responses. So to begin, we are going to talk about a lot of things. Those of you who know me know that I'm pretty much unbridled, and I want to make sure that we appreciate and understand how to identify signs for sepsis and for the deteriorating patient. And then I want to talk about this wonderful methodology that we have to utilize a modified early warning score system, which actually encompasses the deteriorating patient as well as the patient presenting with signs and symptoms of sepsis, and to really recognize those important roles of early intervention and early warning score tools for all types of deteriorating patients, but particularly for patients who have sepsis. So very important for us to always remind ourselves and consider that no matter where we are in the hospital, we care for acute and critical patients. They might not be admitted to a critical care service or an ICU, but we are taking care of these acute patients who can rapidly change in terms of their acuity right under our noses. So the idea is for all of us to identify patients early who are at risk, and also to identify any immediate problems that might kill our patients. And how do we take and perform those quick measures? How do we put that into our incredibly busy days with high acuity patients and over-concerned families and patients as they progress through their journey under our care? Patients who are at high risk for actual or potential life-threatening health problems cover many of the patients that we care for, but in particular the patients who have evolutional sepsis, which actually is very subtle in terms of its presentation. Hence, we've had a lot of difficulty with identifying those patients. But we want to remember that these patients present with a complex myriad of symptoms. They are highly vulnerable, and they are one step at any moment, one step from becoming profoundly unstable and one step closer to death. So we know that our concerns are to do the best possible practice for our patients. So we want to remind ourselves that we work within systems, that we have processes within our systems, and when we are talking about our systemic practice, we talk about our process of identification of patients and identifying patients who are decompensating and how we respond to that process. This is very intricate in its interweb, and no two patients present or respond the same, even if they have the same diagnosis. So we know that patient 1 who has signs and symptoms of sepsis may clearly respond to a quick intervention of fluid and antibiotics, and patient 2 receiving the same therapeutic intervention may not actually respond in the same way. That makes it so complex for us. And then we put that into the healthcare system mode, which is also inherently complex. We have lots of monitoring, we have multiple alarms, most nurses have alarm and alert fatigue, and then we add in more alerts, and our EMR and the time we're spending charting on patients and away from the patient's bedside, and then the integration, such as in my practice, for bedside nurses, APPs, advanced practice providers, residents from level 1 to 4, fellows, attendings, specialists, all coming and going at different times, perhaps spending a week, perhaps spending a month in your unit, and how that affects our ability to actually provide standard care and best practice care, because frequently, of course, even in the best situation, we don't really know the very best therapy, and that often is changing. So we want to build a chain of safety. That's what we do as bedside providers, as nurses, PharmDs, respiratory therapists, and physicians. We are building a chain of safety in our connection to each other and in our observation of our patient. And that we have to build methodologies to recognize deterioration, and even when that deterioration is subtle, to have some form of a system that alerts us to our deteriorating patient, to their condition, and allows us to communicate appropriately and to respond efficiently, intervening, reassessing, and then perhaps escalating care to a higher level of practice. If we're on the hospital unit, in the med-surg unit, to the ICU. If we're in the ICU, to the OR. We have to consider how to build that chain of safety. And one of the most important perspectives is to reduce what I would call human factor science, because we're all fragile as human beings, and we're frazzled as bedside nurses because we have so many acute patients and we're trying to provide the best possible care. So when patients decompensate, it is really important to remember that nearly all arrests that occur both inside the ICU and outside the ICU and in the ED and even outside the ED, most importantly occurs in patients that we know to be unstable. And one of the most important factors which we know across the continuum of care that lets us know that a patient is at risk is shortness of breath and rapid respiratory rate. We know that increases your risk, and that is one of the most evident presentations that keys us to a patient who has the possibility of deterioration. We also know that 84% of cardiac arrests in hospital are preceded by a deterioration of both the respiratory function and then the subsequent level of awareness and alertness. Not necessarily that your patient was awake and now he's comatose, such as we look at with the GCS, but just in terms of mental acuity and awareness, as that starts to change, what we have to consider when we're evaluating those patients is A, that they have shortness of breath or a rapid respiratory rate, and B, that blood is being shunted from the brain, and therefore that patient is presenting with a change in level of consciousness. So these two key points are vitally important in terms of how we embrace and understand identification of patients who are at risk and identification of sepsis patients. We also appreciate that when we look in an evaluation and we look at patients who have had cardiac arrest in hospital, we actually are able to see that those patients have subtle or not so subtle deterioration in the 6 hours pre-arrest. This has been well determined for a long period of time, and one of the major implementation factors in the development of the rapid response teams or medical emergency teams now embedded inside of most of our hospitals in order to quickly mobilize to the bedside of a deteriorating patient and try to identify the cause and do pre-resuscitation of our patients. That's really what helped us to identify rapid response team. And again, depending on where you are, you might be calling a rapid response, you might be calling it medical emergency team, or some other wonderful acronym name. It's all the same thing. It's identifying a highly specialized group of providers. So it may be nurses alone, nurses and respiratory therapists, or in some places, nurses, respiratory therapists, and physician. But these calls are to be triggered by isolated criteria, that's been our history, that are extremely abnormal. So you must be acutely hypotensive or acutely tachycardic or acutely tachypneic before rapid response gets called. But what's happened is we now can reevaluate and say rapid response is called to the bedside when the patient has clearly deteriorated rather than presenting with subtle signs of deterioration. So this is quite important for us to understand and embrace, because what this tells us is that when we have early deterioration is a predictor of your outcome. And how can we actually evaluate patients early? So we're going to take a look at this patient. His pressure is 95/40. Of course, you're alerted to that. His pulse is 116. You might be alerted to that. The respiratory rate is 26 times per minute. You're going to be alerted to that as long as you are actually evaluating the actual rate of respirations, and temperature is 37.8. Pulse ox is 92% on 2-liter cannula, but the patient appears anxious and slightly confused, which is, in this patient, a change from where he was. He has bibasal aroused, decreased bowel sounds, distended abdomen, and warm extremities. So the question I always like to ask is, which of these findings is most concerning? And when we ask about one finding being most concerning, we lose the incredible benefit of aggregating vital signs and actually projecting the rate of deterioration. So, having said that, we're going to move forward and we're going to talk about how we're utilizing vital sign criteria to identify patients early on with sepsis. So everyone who cares for patients with sepsis, I'm positive you're aware of the guideline update known as the Sepsis 3, which was initiated and published in 2016, and what we actually are applying at the bedside when we're identifying patients. So in some frame or another, the majority of us are actually identifying as early as possible patients who are presenting with criteria for sepsis. And we aggregate the criteria of sepsis looking at the heart rate, the respiratory rate, the temperature, and the systolic blood pressure. And now many of us are also incorporating level of consciousness in consideration of alertness, agitation, confusion, responding to voice, responding to pain. So we think about that whole criteria and how we're developing this new definition, which there is a lot of controversy about. So it's I would say 50% support, 50% have some disclaimer about this developing of new definitions and assessing new clinical criteria for sepsis and septic shock, and how we are actually affecting change at our own bedsides, much of which is determined by our CMS guidelines. So we all know that that's going to be helpful because it helps us to drive our practice forward, but we still have to consider what the issues are in patients who have sepsis and how that patient presents to us in an early state and before they have significantly deteriorated. So in order to say that, I just want to define sepsis in the new guidelines for 2016, what we call the Sepsis 3. It was the third evolution of the guidelines, and actually Sepsis 3, third evolution of the guidelines, is also about the 3 most important criteria that we evaluate clinically at the bedside for our patients. And reminding everyone that I'm talking about the clinical bedside identification, not necessarily the integration of the laboratory criteria, but what we need to watch and evaluate at the bedside. So in order to do that, I have to be certain we're all on the same page in understanding the definitions. I'm not arguing whether these are better or worse. I'm just reminding everyone that our definitions in today's world are in 2 categories. First category is sepsis, which is, of course, a life-threatening organ dysfunction caused by dysregulated host response to infection. So what does that mean? It means that you have some stimulus to your autoimmune response, your inflammatory response. And that inflammatory response, which was designed to fight off invaders like surgery, bacteria, other kinds of traumatic injuries, that inflammatory response becomes uncontrolled and now begins to attack the host, the person, the patient. And that further evolution is to septic shock. Septic shock is a subset of sepsis where the attack of our inflammatory response system actually presents as a profound, serious organ dysfunction with cellular and metabolic abnormalities and the inability to maintain vascular tone, and followed relatively quickly by myocardial dysfunction. So what does that mean clinically? What it means to us clinically is the patient is hypotensive and he has metabolic dysregulation as heralded by an increasing lactic acid level. So exactly what you're looking at the bedside. First, thinking about sepsis and defining sepsis with inflammatory response criteria. We used to call it SIRS, and correlating that to septic shock, which is non-responsive blood pressure and lactic acid that is greater. In my institution, we say greater than 2, and then by guidelines may be considered greater than 4. So we think about those new definitions of sepsis, and I love this because it correlates very well to Sepsis 3 and Sepsis 3 definitions. And again, I want to remind you, lots and lots and lots of discussion about this, and that's not our purpose today. Our purpose is to focus on identification of deteriorating patients. So if we look at sepsis 3 definitions, incorporating SIRS criteria but focusing on a presence of altered mental status, a systolic blood pressure that is less than or equal to 100 millimeters of mercury, and a respiratory rate of greater than 22. So when we look at a score of 2 or greater, that is a predictive score for the decompensating patient to organ failure mortality and prompts appropriate intervention. Now this is referred to as a Q-SOFA score. It's a quick sequential organ failure assessment, and so very important for us to remind ourselves, no matter what happens in the big defining criteria, no one has said don't observe systemic inflammatory response syndrome, which would be tachycardia, tachypnea, increased or decreased temperature, correlated now with your systolic blood pressure and correlated with the presence of an altered mental status, which in this case we are assuming is demonstration of poor cerebral blood flow related to this hyperinflammatory response. Incredible and wonderful, and helping us at the bedside to identify our patients. So the change in criteria, for those of us who've been around a long time, we used to talk about sepsis as infection and 2 or more SIRS, but now we say sepsis is infection with organ involvement. And we used to say the word severe sepsis, but that's now what we call sepsis. So SIRS plus infection plus organ dysfunction is now called sepsis. That's the change. And septic shock is a blood lactate by definition of greater than 4 millimoles despite volume resuscitation, and hypotension that persists after fluid resuscitation and requires vasopressors. Now the concern in the overall community is this will lead to our missing of patients, because earlier we were identifying patients with simple SIRS criteria, tachycardia, tachypnea, temperature change, not requiring a change in our blood pressure and not requiring organ dysfunction for early identification. Now, part of the reason that change occurred is because we were embracing every single sick patient in the hospital, septic or not. If they're sick, they met some of the SIRS criteria. So the goal was to actually give us a laser focus on patients who have sepsis. And again, remember, I'm not including laboratory analysis here, even though of course that's incredibly important. And also suspicion of infection, which is incredibly important. We can completely understand that. So the problem is that as we change our criteria for identifying patients and no longer saying SIRS, sepsis, severe sepsis, and septic shock, but just saying sepsis or septic shock, our concern is that we might not be identifying patients who are in early stages of hyperinflammation, but not yet with organ dysfunction. So I'm going to try to give you a little bit of an answer to that. And just in case you missed it, I'm just going to remind you that SIRS criteria was temperature up or down, heart rate up, and of course only if the patient can manage that. If he's on beta blocks, then you might miss that part of the criteria, and a rapid respiratory rate. And then including in that, and when you do an arterial or venous blood gas, looking at your PaCO2 of less than 32, which would correlate to a PvCO2 of less than 38. If all you're looking at is your venous gas, but you're actually doing that through a methodology to actually evaluate the blood gas rather than just the levels. And then evaluation on laboratory analysis of a white count that is up, that is down, or that has at least 10% of immature neutrophils, and that's, of course, a very important component. And we always understood SIRS to be a body's response, the host response to infection, inflammation, or significant physiologic stress. So now we talk about Q-SOFA. And again, there's a lot of controversy about this, but Q-SOFA actually takes the three most important predictors of deterioration, which is a rapid respiratory rate, a change in the mentation from the stable mentation state. So if we're using GCS, that would be a GCS of less than 15, but also looking at alert and awake, response to voice, response to pain, completely disorganized thought, all of those components, and when we're evaluating altered cognition, and systolic blood pressure of less than 100. Now, the presence of any two of those criteria in the Q-SOFA score actually identify to us with that we have a patient who is deteriorating. And if they also have a known or suspected infection, we believe they are deteriorating in sepsis. So patient is deteriorating, and then we narrow in and say, is there known or suspected infection? And if the answer to that is yes, then we identify that that patient has sepsis. So now I want to bring up my clinical scenario again and say his blood pressure is 95, less than 100. His pulse is 116. That's very concerning from a SIRS criteria perspective, but not from a Q-SOFA. Respiratory rate is 26. That's going to meet both SIRS criteria and Q-SOFA. And then the really big deal, really big deal, patient appears anxious and confused. Hey, he's got bibasal rounds, he's got decreased bowel sounds, a distended abdomen, warm extremities. Those are really important to us in our evaluation of the patient and in our suspicion for infection. But from a Q-SOFA perspective, your patient has a score of 3. And if we believe he also has an infection, we suspect it or we know it, that patient is septic. Now, these are pretty simple strategic evaluative tools. So, does our patient meet Q-SOFA? Yes, 3 points. Does he meet SIRS? Yes, he has 2 points. So, we wanted to strategize this into an electronic evidence-based alert methodology. So at my hospital, Grady Health Systems in Atlanta, Georgia, we utilize EPIC, and I want to just give a quick shout out to 2 groups of people, actually 3. Number 1, our incredible EPIC team. Number 2, our vibrant, energetic, and always on the spot rapid response team. And number 3, my critical care vice president, Mary Marshman, who had tremendous ability to look forward to identifying patients early with modified early warning score tools, and to Carmen Polito, who's our sepsis physician champion. And we are all working together as we evolve methodologies to bring forward patients who are deteriorating. So for us, the first step when we're talking about sepsis, the first step is if you are outside of the ICU, your patient care tech, your nursing assistant, your nursing tech, or the bedside nurse, evaluating a patient and putting their vital signs in real time right now into our electronic medical record. If our patients meet 2 abnormal vital sign criteria, as you see here in the red box, EPIC alert fires. That's a best practice alert, and it requires that the nurse is notified right now. So if my tech has put those vital signs in, my tech is requested and required to notify the nurse. So then the nurse becomes notified to the patient because there's been that early identification trigger, and the patient must meet at least 2 from that following list. So in our busy medical surgical ward, we strive to identify vital signs every 4 to 6 hours, depending on the patient, but absolute requirement is every 12 hours in a non-acute patient. So our first BPA sepsis alert, and this is an early version. We've had some rotation of the version, but this is a beautiful version to show you because this is what we did first. We get a best practice alert. It's called a hard stop. You can't go any further. You have this big suspected sepsis alert that says, stop, your patient meets vital sign criteria for sepsis, and you can see the patient that was identified here, and the words that say, tech, you must immediately alert the nurse. And the tech has to toggle in under that hard stop and acknowledge the nurse that they've notified or the reason they haven't notified. And so the second response is the nurse who is responsible for the patient. If they were the ones who recognized the vital sign changes initially, they have to do a second evaluation. Or if the tech recognized the vital signs initially, the nurse now is required to come to the bedside immediately, and the nurse is the only one who can actually do full response to the sepsis alert. They utilize and document on a sepsis assessment flow sheet, confirms, actually reevaluates the vital signs and confirms that the patient has at least 2 abnormal vital signs, assures that those abnormal vital signs are acute changes to the patient's condition, meaning they haven't had this abnormality since the day they got to the hospital, and it's 3 weeks and it's the same abnormality and patient's been assessed over and over again. And then all the bedside nurse must do at this point is to actually assure that those vital signs are acute changes and actually indicate whether or not they believe that there's a possibility for infection or a documented infection. And then what they do is they call our in-hospital, I repeat, not out of the hospital, in-hospital 911. That operator then sends out an alert called code sepsis, and code sepsis calls everyone to the bedside. So this just shows you that second alert, the sepsis alert that requires the nurse to again evaluate the vital signs, asking the bedside nurse to immediately complete a sepsis assessment, which is located on their vital sign flow sheet, and also gives them some annotations that they can choose: not indicated, hospice patient, unchanged, patient has known sepsis, already being treated. And once they call that initial code sepsis, the in-house 911, the operator actually sends out a message, and you can see the message on your slide to the right. This is the text message that all of the stakeholders, so that includes pharmacist, rapid response, respiratory therapy, and physician, that we all are, oh, I'm so sorry, and the lab, all identified that we have a patient who's met criteria for sepsis. We call that code sepsis. You have 15 minutes for the team to arrive at the bedside. Now, pharmacy does not need to arrive. They just need to know they've been alerted. So in 15 minutes, the team comes to the bedside for the code sepsis. So I'm going to show you an early protocol for the med-surg and intermediate care areas at Grady Hospital, which is a huge hospital, by the way, and it's a safety net hospital. And what you just basically see here is the bedside nurse assessment after the tech has informed the patient. So remind yourself, first alert, second alert, bedside nurse then initiates code sepsis, and the rapid response team is notified, and the bedside nurse calls the primary team as well. And then within 15 minutes, rapid response has to arrive at the bedside, review the vital signs, and assess the mental status. And again, ask the question, is there a new suspected infection? And then they will consult with their medical physicians. But we have built into our profile that rapid response will work with phlebotomists to draw all the necessary labs, and that would include lactate plus blood cultures ×2 from 2 different sites, and only the phlebotomist does that. We don't do that as nurses. We can draw all the other labs, but not the blood cultures. And then rapid response, based on their assessment of the patient, will initiate a rapid fluid challenge, which means we're going to give that fluid in less than 5 minutes. And we give that fluid for a MAP that's less than 65 or systolic pressure that's less than 90. That's been one of our updates. And then they are consulting with the MD to receive an antibiotic order. Our pharmacy actually has a commitment to verify the antibiotics and, if necessary, to deliver the antibiotics, although the majority of broad-spectrum antibiotics are in our Pyxis system, so this is quite beautiful. And that rapid response team member working with the physician will then actually determine, is the patient actually septic, and if they are actually septic, our rapid response documents on their sepsis flow sheet. Our physician uses a code sepsis initial evaluation, and by 1 hour, we are required to have completed what would traditionally be called the 3-hour bundle for sepsis, which is all labs done, fluid is administered. The rapid response does the first 500, but we still work for 30 mLs per kg. So by 1 hour, if everyone agrees the patient has sepsis based on indicators, not on lab, based on indicators, we will resuscitate patients with 30 mLs per kg of lactated ringers if the patient's systolic blood pressure is less than 90. By 1 hour, our antibiotics must be hung and infusing. And we hang that antibiotic at the last minutes of that 1 hour because we want to be sure we got the blood culture drawn. So we're drawing our labs, we're drawing the blood culture, we're giving the fluids, we hang the antibiotics. We have a great team of communication at the bedside, rapid response, bedside nurse, physician, lab, respiratory therapy, who is drawing the blood gas if that's necessary, and we're all working acutely together. And I'm talking about in a huge hospital, safety net hospital, that has a wide variety of young doctors in training, academics, and attending physicians, and many services. So again, our sepsis team is the bedside team, the bedside physician, the bedside nurse, the rapid response team, the phlebotomist, pharmacy, and respiratory therapy. That's our core code sepsis team. All actually notified via a text message to their cell phones that says, we have a code sepsis, it's in room 5 on 5A, everyone come to the bedside. And so far, it's worked beautifully. So remember what rapid response does, and how we've empowered rapid response is to initiate that fluid challenge as fast as possible. Try to give that fluid within 5 minutes if the systolic blood pressure is less than 90, and then to make sure the labs are drawn for confirming a diagnosis. Now the physician arrives, and because we have a wide variety of physicians, we have a fabulous infectious disease stakeholder who is identified based on our average antigens and nidus of infection for every single system. All that physician has to do is click onto the system, and the recommended dual antibiotics are actually projected, and then the physician just has to click it and it's ordered. And because pharmacy has been notified, you know, our pharmacists are mixing drugs for 1,000 patients. So the pharmacist now knows this is a sepsis antibiotic, and it moves to the very top of the queue. And that antibiotic, if they have to mix it, arrives to us within 60 minutes. We hang it and we go forward. We do actually give fluids to patients who have congestive failure or end-stage renal disease or dialysis patients, because if they've been identified as having sepsis, they also need vascular and myocardial resuscitation via aggressive fluid resuscitation. So we just slow it down a little. If we're giving fluids 30 mLs per kg, we're going to give it as fast as possible, trying for 15 minutes. We don't use a pump. We use a pressure bag. We don't use a pump because you're limited. Your pump only goes to 999. You got to get this fluid in fast, 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 fast. We're going to give it a little bit slower if you have congestive heart failure or if you are a renal failure patient. Beautiful. Okay, so always really important. I think I've covered this pretty well, and I'm so sorry because I hate to be redundant, but just to remind you, rapid response takes that evaluation to a little bit higher plane. Infection suspicion, changes in mental status using GCS or AVPU, alert, verbal, pain, or unconscious, and if there's a high suspicion for sepsis. So we just escalate a little to the rapid response, working together with the bedside team. And I wanted to share with you our beautiful rapid response driven sepsis order set. So you can evaluate this as within 45 minutes. All labs were drawn within 60 minutes. The patient must have fluids if their MAP or their systolic pressure is low. And antibiotics must be initiated within 60 minutes. We have a 60-minute clock, and as many of you know, much of the recent literature actually advocates that you work within a 60-minute clock. So what that means is the 3-hour bundle as promoted by CMS, we're done with that at 1 hour. At 3 hours, our rapid response team draws the second lactate or advocates for the second lactate to be drawn, and we reassess the patient at 3 hours, and actually we have a little wider frame, 3 to 4 hours, and when our rapid response team comes back to reassess the patient and they meet with the doctor and they reassess the patient, we then escalate to the 6-hour bundle, but we start that at 3 hours. So really at Grady, we're operating with a 1-hour bundle and a 3-hour bundle. And the way you would think of that would be a 3-hour bundle and a 6-hour bundle, but we use the 3-hour bundle, which is drawing your labs, giving your fluids, hanging your antibiotics. We actually initiate that within 60 minutes of identification. And our 6-hour bundle, which is more fluids, and if the patient is fluid responsive, more fluids, and if they're not fluid responsive, advocating for vasopressors, escalating to a higher level of care, and then integrating all organ support necessary. We actually look at the patient at 3 to 4 hours, and we move forward to what's known as the 6-hour bundle. So we have a beautiful history. On April 3rd in 2017, we went live on 2 pilot units, 1 medical surge and 1 step down, and educating bedside nurses to do sepsis shift assessment, and the compliance was greater than 90%. In no small way contributed to Kimberly Hare, who is a wonderful educator who actually assured that all the floor nurses, which we call floor nurses, were all educated in sepsis shift assessment. And then on April 19th of 2017, we went live, we evaluated what we'd done, and we saw that rapid response was only using 21% of the order set, 63% of the MDs were using the order set, and 42% our MDs were using what we call a code sepsis note. So we were looking at that and we went back and said, why is this so? Because our rapid response team, they're so amazing. So we went forward with our rapid response and we re-identified that no matter what, they should fill out their order set. So when we re-evaluated July 3rd, 2018, all units in our hospital were live with sepsis. So this is just a recent re-evaluation. We've had 25% true activations, saved 68 lives because of activation, and utilizing our rapid response order set 99% of the time, 58% MD order set used, 34% MD note used. So what we actually uncovered here was that we really were having some problems identifying who's really sick. Who's infected with decompensation, and it's very difficult for us to identify who's really sick because that's an indirect surrogate signal, and we always have to consider that. So again, we think about our rapid response team and we remind ourselves that even though using rapid response, from Hillman's great work, looking at rapid response and response to patients who using that as an intervention and looking at the difference between unplanned ICU transfer, unexpected death, and cardiac arrest, the number one question is, what if we get to them sooner? What if we can get to them sooner? So very important to appreciate the role of the rapid response team, but also to appreciate that rapid response has to be contacted before a significant change in vital signs occur. That's when we started looking at Muse. And we did Muse after we had identified sepsis to identify patients more effectively and more assertively prior to deterioration, prior to code, by using an aggregate scoring tool for this multiple criteria. Now, this gives us a much better methodology to identify patients. And to add Muse to the mix actually increased the patients that we were calling for rapid response, but actually helped us to focus on the sickest patients. So really, really important to understand Muse. Muse is based on 5 bedside parameters. Muse is a modified early warning score, and it's been in the literature for quite a while. It's a very simple score for identification using 5 bedside parameters: systolic blood pressure, heart rate, respiratory rate, temperature, and level of consciousness, measured by either a RASS score or by alert, voice response, pain response, or unconscious, alert to agitated. And this scoring tool has been shown to predict hospital mortality at a very significant high level rate, predicting cardiac arrest, predicting ICU admission, and increasing our rapid response calls. So we have these groups of aggregates: the low score group, the medium score group, and the high score group, that is identified based on the modified early warning score tool. That's a really important aspect, because we know that early warning score tools actually help us identify patients much earlier. And it's been very highly validated in resuscitation and shock, and the way in which we can identify patients early on. So the literature really supports that, looking at those subtle changes that are apparent. They're subtle, but they're aggregated together. So it's not just one vital sign that is severely abnormal, it's the aggregate of the vital signs. So we are now using Muse in all of our floor patients and intermediate patients to identify a patient's early deterioration. So I think always very important to understand the specific goals, and this beautiful visionary perspective of our Vice President of Critical Care was to identify patients who were at risk, to intervene in a more timely manner, and to improve communication between nurses and doctors. So you can look for the early warning score anywhere on the internet, but basic scoring just says anybody who is within normal ranges, which you would identify in your own system, anybody in normal ranges gets a score of 0. But they have outliers with heart rate down or heart rate up. When you meet those criteria, you get a point. And you can see what that lovely scoring system shows us. So now we go back to our case and we say, now we're going to look at this patient and identify his Muse score. Okay, so remember his blood pressure was 96, so what that systolic blood pressure means is that he gets score 1. That his pulse was 116, so what that means, of course, is that he gets a score 2. Respiratory rate was 26, and he gets a score 1. And he appears anxious and confused, which means he has an abnormal evaluation of his level of consciousness. That's a score 1. So as long as you can add, you can see that our patient's score is 5. That means that patient is significantly at risk for deterioration. So we have many ways that we can evaluate this. This is how we're using the Muse at our bedside. And again, we have a best practice identifier that says real-time, right now, vital signs entry, and then a Muse level of consciousness score. So we are able to evaluate and document vital signs in real time, utilize a neurologic Muse score, which is so important, reminding us that it's alert, agitated, confused, or responding to voice, responding to pain, or unresponsive. So what we want to consider is how incredibly well this has been implemented at our health system. So I'm going to move to this beautiful slide here to just show you that when we chart our vital signs, we also have this Muse level of consciousness assessment, and that helps us to identify patients at risk. If patients are at risk, we get an epic, from our electronic medical record, we get an epic identification of patients at risk. So very importantly, we actually have been able to significantly and profoundly and accurately identify our patients at risk, because the Muse score of 5 or a change of greater than 2 actually causes a Muse identification score that fires and identifies that we have deteriorating patients under our care. So I want to actually correlate that now to our practice at Grady, and to say that for our practice at Grady, what we're seeing is we're having 400 Muse identifications, 400 Muse identifications per month, and we have significantly increased our burden for rapid response. We've increased our rapid response therapy therapists, our nurses that have been brought on board for rapid response. And I do want to make sure we all appreciate there are always issues. There are always issues with implementation, concerns regarding team education. We have some physician resistance, sometimes physician disregard. We have over and under resuscitation, and we've changed our language. So take home points here: optimize your process, build a chain of safety, build a safety net, report and educate. Mandatory training for all providers, physicians, nurses, pharmacists, and respiratory therapists. Review your cases and then target your feedback to wins and opportunities for change. So I want to say thank you so much. I want to add, again, a call out to my rapid response team, to our sepsis team, to our vice president of critical care and our physician leaders, to Angela and to Phillips. Thank you so much, and continue to fight that fight against sepsis and deterioration. Thank you. Take it away, Angela.
All right. Thank you, Barb, for this most informative webinar. I would like to remind everyone that we do have continuing education for nurses and respiratory therapists, and that this educational activity is approved for 1 contact hour. To obtain your CE credit, you are going to go to saxtesting.com/BO. And support for this educational activity has been provided by Phillips, and there is other information on that slide as well regarding your certificate. Now, I have received some excellent questions, so we're just going to get started. Barbara, the first question I have is from Greg. Any thoughts on data showing capnography may serve as a non-invasive continuous surrogate for lactate?
Thank you. That's such a great question. What I would tell you is that capnography is an incredibly valuable tool in evaluation of patients, and particularly in patients at risk. It is important to remember that it is a measurement of cellular respiration and exhaled CO2. So we have to be sure that it's first of all, that it's calibrated and that it's very significantly usable, and that users know how to validate and assure it. So it's a great tool, but I think in terms of identifying deteriorating patients or septic patients who are not actually intubated, it may not be quite as helpful for us, but that remains to be seen. What do you think, Angela?
Yeah, you know, we use it more in our pre-hospital setting. So our EMS system here just recently rolled out the early detection in the rig and literally getting blood cultures and giving antibiotics there. And they are using capnography to kind of determine where they might be on a lactate level. So that's where I've seen that used more, at least here in my area. All right, let's look at another question. Macy asked the question, have you applied any of this to the new admissions in the emergency department?
Fabulous question. We are not using Muse currently in the emergency department, but we do have a rigorous sepsis identification criteria that is particular to the ED. It actually dovetails with our inpatient evaluation. We don't actually send rapid response currently to the emergency department because their physicians are so clearly in place, but they have a beautiful tool, and it's been revised 6 times because initially, our very early tool, we were getting 100 sepsis notifications a day in the ED, and some percent, probably 70%, were not actually septic. So it continues to be revised, but we have a rigorous ED sepsis identification tool. Angela, how about you?
Yes, so we do, we have an electronic screening that is done when they arrive. And so they kind of do their own thing because we've got a system that's a little different in our ED than what's on our floor. So they, it's electronic, and they do that, and that is the expectation down in our emergency department as well. With the goal in mind, we try to do everything in an hour as well. Lots of other great questions. I know I'm going quickly here, but we want to get to as many as we can. We have someone who asked, since you are on Epic, have you considered implementing any of the predictive analytics tools for sepsis or deterioration?
Great question. So we certainly have. We have been working on the development of something that's very rigorous in terms of predictive analytics, and perhaps the next time I see you or you hear from me, I'll be able to share more with you about what we're doing with the model. But we're not using the model as is. We have found that that's not as controlled in terms of identification as we would like.
I have a question from Christina that says, do your physicians prefer lactated ringers over normal saline for fluid resuscitation? Their site primarily uses normal saline, and there's been some recent education and literature that's come out. So do you want to elaborate on that?
I certainly do. So here's the rule of thumb. Whatever fluid you've got for your first fluid resuscitation, use it. But what we know, and what we've known for quite a while, is that sodium chloride dissociates when it's administered to your patient. It actually supports the development of hyperchloremic metabolic acidosis. It is also considered to be renally detrimental. So the way to look this up, if you'd like to read more about it, which I hope you will, is to use the term balanced versus unbalanced crystalloid. We choose balanced crystalloid because it's more host-friendly with a pH that is more similar to our patient's blood pH, and a balanced crystalloid would be lactated ringers or Plasma-Lite. Unbalanced crystalloid is normal saline. So please read more about it because it's such a great thing to discuss. But remember, fluid first, and if all you have is normal saline, don't sink your boat over this discussion.
Great thoughts. Another question came in from Jeff. How do you manage alerts for patients whose vital signs fall within normal parameters because of medication but may indicate deterioration, like beta blockers, antipyretics, etc.?
So what an excellent question. Thank you so much. We have not gotten to a sophistication level to be able to say, okay, well, your heart rate's 80 and that's 10 above what your normal is, but it's 80 because you're on a beta block. We're still required, all of our alerts still don't actually reduce the level of critical analysis at the bedside by the bedside nurse. But it's a continuous educational uplift that we have to say your patient might not be tachycardic because you're on beta blockers, or you have sinus node exit block, or some other cause. And we don't actually look at the administration of antipyretics and say, hey, your patient had a temperature, now they don't. This now still requires critical analysis by the bedside provider, and alerts really are more static. They are really based, Muse alert and sepsis alert are based primarily electronically, are based on the abnormality of the vital signs without the contingent for the management that's been performed by the patient, their wife or husband, or by the nurse. We have not built that in yet. How about you, Angela?
Yeah, this is really, I'm really passionate about this because this is where the education of our nurses and our staff is still so essential that we cannot just count on a Muse system to know everything. Do we use it and is it fabulous? Absolutely. But without the knowledge base and without the critical thinking, I think we'll really miss out. So don't you agree that we still need to educate fairly rigorously our staff, or I don't know if rigorous is the right word, but don't we need to really make that a very important part of our onboarding and of our continuing education of our staff?
Well, absolutely, Angela, and thank you for saying that. Of course, education is paramount, but it also is important to remind ourselves that the criteria for Muse, particularly for Muse, but also for sepsis, is looking at aggregation of abnormal signs that are subtle. Now, sometimes your signs are profoundly altered. So even if my patient's on a beta block, they may have some variability that gives them a change in their score. And that's why we aggregate those vital signs rather than look at them as singular presentations. But I think over time we'll see even more development and more rigorous communication from the MAR to the vital signs to actually allow us to alert on patients that actually are meeting some abnormal criteria but don't fit into those very significant standardized parameters.
Yes, good point. Good point. And Adrian asks, with those CHF patients, are you using any airway interventions like BiPAP or CPAP while administering fluid resuscitation?
If necessary, yes, absolutely. And I would just say I'm a very big BiPAP supporter, and particularly when we're looking at patients who are deteriorating. However, if we are giving fluid and our patient becomes short of breath, then we clearly didn't make the best decision. It may be that they needed fluid, but if their myocardium cannot handle that fluid, then you escalate to a higher level of question of, do they have worsening myocardial dysfunction? Do we need to add some low-dose inotrope? And that takes it into another realm of critical care. So I think we don't say, let's put BiPAP on the patient who we're going to give fluid because we suspect that they have sepsis and we know they have CHF. We give the fluid, we do it more slowly, we then continue to evaluate, and then if necessary, we will escalate therapeutic intervention to promote better gas exchange using something like BiPAP or CPAP. Thank you, great question.
Yeah, excellent. Another question came from Catherine. Are you typically administering vancomycin, barring allergies, as your first-line antibiotics? And if using Zosyn, are you using a rapid infusion versus extended rate for that first dose? And I will speak up to this just quickly because I'm all about that first dose being stat and giving it as quickly as possible. So at our institution, when we do give Zosyn, that first dose is a stat dose here. It is more of the rapid infusion versus a longer infusion. And I know antibiotics, for us, we really look at our antibiograms of our different hospitals to determine what is best. We use a lot of Zosyn and Vanc here at our institution. How about you, Barbara?
Same, and we consider those first administrations as being stat drugs, and that's how they're actually framed, as stat drugs. We are also evolving a perspective now to consider that the first stat administration of agent will be within the hands of the rapid response team. That's requiring a lot of discussion and evaluation, but because of the importance of that early antibiotic administration, particularly in the hypotensive patient, we really want to limit as much as possible human factor. We want to give that drug really quickly, and we do rapid administration of Zosyn for that first dose.
Okay, excellent. And I have a lot of different EPIC questions, so I'm going to try to give these to you really quickly. How long does it generally take for your hospital to implement changes to EPIC? And this person felt it may be a little frustrated. It just seems to be extremely slow at her hospital, sometimes months.
So what I would tell you is, and especially in my hospital, is that we have a really great EPIC team, and there's a lot of providers, nurse providers, and physician providers on our EPIC team. In general, when we're making smaller changes. And when we're making changes that are not about life-threatening illness, it takes a little longer. But our team has encompassed people in all levels of EPIC, and so we are actually, we build, we test, we rebuild, we test, we evaluate, we change, we rebuild, we test. But because EPIC is at the table of everything we discuss with Muse and sepsis, because they're with us at the table, I think that the time between the development in terms of the strategic critical thought development and the implementation has really become shorter at my institution, really become short. And so now when we're looking at changes, EPIC build changes, we really can create changes within one to 2 weeks, and sometimes even shorter, depending on what's encompassed into that EPIC change. So I think for us, actually bringing these EPIC team members and programmers and then the analytics from EPIC all together with us at our sepsis table. By the way, today I have a sepsis committee meeting at 3 o'clock. We always have at least 4 EPIC programmers at our table, and that has really changed how we are progressing.
Excellent. And did you have to customize your EPIC platform to create the critical advisory for sepsis?
Yes, we did.
Okay. All right, and you know, I hate to say it, but I'm sorry we are out of time. We couldn't get to all the questions, but I am going to hand this back over to Emily to finish this up for us.
I'd like to thank you very much for your time, both Barbara, for this informative presentation, and as well to you, Angela, for being our moderator today. It's been such a pleasure working with you both. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Thank you, everyone. Take care, and we'll see you again next time.